Thank you very much and good morning. It's an honor to be here, and thank you to PK for the invitation. My disclosure is I've been leading a limb preservation center in the VA at Loma Linda, California for about 16 years now, and I just got tasked to develop one at the university. So the prevalence of renal failure and diabetes makes wound healing and limb preservation an increasing clinical important task to be accomplished for patients and healthcare systems. There is a large variation in the United States, at least, in the terms of the care delivered to this type of patients based on geographic, race, socioeconomic status, and insurance status. From the system perspective, today, we have a fragmented approach, limb preservation, in terms of silo-type models. This leads to inefficiency, underutilization, over-utilization of resources, the lack of able to validate your own internal practices, for you don't have QA registries, and to me, more dangerous than anything else, assumptions that things are going to do just fine once you do the procedure. From the patient's perspective, when you're trying to navigate this complex system, certainly it's frustration and negative perceptions. So in the 21st century, I think we all agree that teams are better than individuals. The multidisciplinary approach has been sanctioned by American Heart Association, Diabetes Association, SVS, and others as a way to approach this very challenging disease process. Of course, from the system perspective, advantages includes efficiency management of complex patients, as well as the ability to coordinate with physicians, nurses, and care providers these complex patients. Now, we have a patient-centered philosophy of care. It's team, not individuals, caring for individual patients. And every patient is actually quite unique. Now, there's certain models out there. I've been around and observed certain different models. In the VA, for example, we have kind of a single command and control, which we have a director, and then if you have a financial interest, you will have your financial person. That's one model. Then you have other models that are most often kind of patient steward, in which they go from referral to referral, and you have to have somebody trying to coordinate this type of care. And then I think a model that works when you don't have a financial structure that is an umbrella for all the people involved, a shared consciousness state, which is really a set of shared beliefs, ideas, and attitudes that everybody operates as a team. In order to have success, you have to kill the ego, and this is quite challenging, to be honest, in lots of settings. But I think once you get over the ego and once you understand that as a team effort, you are there to take care of patients, I think things actually work quite well. This is our mission: to preserve limb integrity, heal, and improve our patients' life and health. Now, the building blocks for a limb preservation center includes the staff, the community relationships and marketing, as well as geographic components. The staff, you have to have a leader, you have to have a champion that kind of coordinates ultimately things. And you may be able to have lots of people under your staff, or maybe you have to wear more than one hat. But I think the key components include the clinical coordinator, person who is able to develop registries and longitudinal follow-up clinically, research coordinator, QA coordinator, and financial staff, and then competent healthcare providers at all levels, competent supporting staff at all levels, and then you will be interacting with rehabilitation, prosthetics, pharmacy, diabetes, infectious disease, foot and ankle, and plastic surgery as well. In terms of the community relationship early on as you develop your center, I think your more important target will be your internal community. After you're done with that, referral community actually starts on its own, to be honest. Social media is kind of the thing in 21st century. And then appeal to your local or regional chapters, the American Heart Association and American Diabetes Association. They're actually quite helpful in terms of projecting your program to the community. Geographic components, I think outpatient office-based labs, endovascular labs, hybrid rooms. I think you have to have your non-invasive labs involved in your clinics, wound regeneration clinics, and HBO, if you have that availability as well, to complete the wound and regeneration component of the program. This is actually our structure. You have clinical services, we have research and education services, the QA, as well as the outreach services. I'll concentrate mainly on the clinical services, and these are the four branches, if you may: the outpatient clinics, when there is initial evaluation of patients and the comprehensive follow-up. We have limb preservation, the in-service limb service, which is the rounds on inpatient hospitals, then the interventional branch, which is the outpatient labs, the OR, as well as the cath labs, and then the surveillance branch, which happens in a virtual model, really, by our coordinator, surveillance coordinator. The flow, the outpatient is fairly straightforward. We have either cardiology or vascular evaluating patients. Then we all kind of commune together in a multidisciplinary stratification conference where we adjudicate a treatment strategy, when procedure is performed, and then a follow-up of this patient is being followed, and then the outcome of monitoring, and eventually goes to a QA, and then we got quarterly and annually reports to the whole group of patients, see where we are, what have we learned, do we need to revisit issues, strategies, etc. From the inpatient perspective, it's kind of the same thing, but we have a large rounding once a week with everybody together, and then we present all those patients who are in-house, and then it's kind of the same flow. The key component of we learn over the years is, no matter how wonderful the job you do in the inpatient side, transitional care, it's really the Achilles heel, and we actually develop a lot of time in our coordinators, our limb preservation coordinator, to interact with the healthcare systems that are either SNF facilities or home health care, trying to not decrease the level of support of these patients need in order to successfully heal the wounds and become maintain functional. This is kind of what we use in terms of the presentation of the criteria with the Wi-Fi classification, and we'll talk a little bit more about this in the wound classification this afternoon. But there are still really large two sets of presentations for our patients, the infected and the non-infected patient. The infected patient really is about the stratification of the infection, whether it's mild, moderate, and severe, whether it's soft tissue involvement or bone involvement, and then certainly about the management is, regardless of the ischemic profile, they need to have antibiotics and they need to be debrided surgically or open amputations. Now, most of the time we're able to control the infection, and patients who present without an infected wound, when we approach them in the algorithm as follow, we perform offloading, edema control, metabolic control, systemic level nutrition, and then we stratify on non-ischemic and in ischemic settings. And you know that you have arterial ulcers particularly, or gangrene, which is an index for arterial insufficiency, severe arterial insufficiency, as well as DFU, diabetic foot ulcers with arterial insufficiency, or venous leg ulcers, very rarely with arterial insufficiency as well as pressure ulcers or traumatic wounds with arterial insufficiency. And all these patients are presented at this multidisciplinary conference that really kind of builds the cultural backbone of the whole team. You present the cases, or the fellows present the cases, the residents present the cases. We adjudicate the treatment strategy, fosters a team culture, and it really is a forum for ongoing growth for all of us. This is kind of our intention to treat, and we presented this many years ago now, based on all the algorithms of care. I think most patients with ischemia, significant ischemia, will benefit from revascularization. There is a subset of subcritical ischemia, if you may, that you may be able to try successfully conservative approach or a delay revascularization option. There are some patients that continue to benefit from primary amputation, and some of them will actually receive palliative limb care. And this is kind of our inclusion criteria for each one of these groups, and these are all different patients. Every patient is unique and will have a unique presentation, and this is kind of the inclusion criteria for each one of them, and this is kind of the philosophy behind each one of the intention to treat analysis. This is a typical format of presentation of our patients when we present at our conferences, and eventually you talk about the patient, the anatomic, and the vascular perfusion, as well as the index wound, and we intention to treat stratified for, in this case, revascularization. And we have published our data and long-term data. We got about 10 years of mature data as we speak. And you can see the demographics for the revascularization and the conservative patients. There's no really significant clinical difference between the two, except, of course, the degree of ischemia. You can see ABIs, TCPO2s, and ankle pressures have a lower values in the revascularization, more ischemic group of patients. In terms of the prevalence of the wound location, there's no really clinically significant differences, but the wound types are different. The ischemic patients, the revascularization patients, tend to have more common gangrene as a presentation, versus ulcer patients, who tend to be more common in the conservative approach. In terms of the healing percentage, there's no really significant difference between the two, and again, these are two subsets that are completely different based on the degree of ischemia, utilizing TCPO2 as the modality of choice for screening the degree of ischemia. But you see here that the time to heal, it takes longer, and it's probably because of there are sicker patients, maybe larger burden of disease. The time to heal, the mean time to heal for the revascularization patients is about 6 months or so versus the conservative patient, which is about 4 months or so. In terms of the recurrence rates, they are essentially the same, and active essentially the same. So once we are done with the inpatient procedure, or they are in the house for wound management, we do transitional care. Again, significant coordination with transitional facilities or home care systems. And then we perform the outpatient. Am I the one doing that? No. Okay. Outpatient clinics, when we address the atherothrombosis prevention, wound management strategies, the vascular patency, or the functional outcome of the patients. This is the atherothrombosis prevention strategies that we do, and these are all according to AHA guidelines. This is the type of wound approach that we do for all our patients, and this is the fate of the wounds, if you may. You see that a wound can heal or not heal, and then we need to do something else. And when they heal, they may remain healed, or they actually have recurrences. And we estimate in our revascularization setting a recurrence rate of about 16 to 20%, and in their medical treated patients, the conservative patients, at about a 32% recurrence rate. So these patients, when you follow them long enough, you'll actually see recurrence. They're very similar to cancer patients, really. And then from the hemodynamic perspective, we have the surveillance protocol to evaluate the interventions, whether endovascular or open interventions. We have a very aggressive surveillance protocol, and this is kind of what we use in terms of reintervention and what do we do with those. So with that, thank you very much for your attention.
Well, thank you very much.